Dah ke ni? Dah start record ke ni? Dah start record eh?
Dah, okay.
Alright, okay. Thank you so much. Okay, now I'm going to share with you my lecture slides. Mana? Desktop code. Desktop. Okay, what should I do? Okay. Alright, Assalamualaikum. I'm Dr. Ruzi from Department of Pathology. Today I'm going to give you a lecture on neuromuscular junction and non-neoplastic skeletal muscle diseases. Okay, if you cannot hear my voice, please let me know because I would like to try my best. This is my first live concert. Thank you for coming, everyone. So for this lecture, the specific learning outcome of this lecture is for you to know about, there's a pointer. Okay, to know about myasthenia gravis, musculodystrophies, and also inflammatory myopathies. So after this lecture, you should know the etiology of these three, the pathogenesis, the clinical manifestation, and also the complication. Okay. So tak banyak pun, 3 je. Okay, this one is the screenshot from your favorite book, Robin. Okay, so here as you can see, under disorder of neuromuscular junction, I will talk about myasthenia gravis. And then under skeletal muscle, the disorder of the skeletal muscle, I will be talking about inherited disease of skeletal muscle and also acquired disorder of skeletal muscle. Okay. 3 je, sabar 1 jam, do not fall asleep. Okay, as an overview,
Doktor termute.
You.
Doktor. Doktor, tak ada suara, doktor.
Doktor termute lah.
okay now, can you hear me?
Okey, dah dengar.
Okey sekarang dah.
Aduh, penat
Kan,
dah
doktor.
masuk slide 3 dah ni. So since the beginning you tak dengar?
Tak.
Slide 3.
Okay.
Baru
Slide
je.
3.
Learning
Okey, slide 3
dengar je.
Sini, yang ni kan?
Sampai favorite book.
Okay, favorite book. Okay. Alright, so favorite book dah settle. You all tak nampak muka I sekarang kan?
Nampak.
Nampak doktor.
Sorry, this is my first live lecture, so I tak sure. Okay, so now, let's get back to our business. Okay, now you all dah belajar CNS. So CNS consists of our brain and also our spinal cord. And then we have peripheral nerve. Manalah laser pointer ni? Okay. Alright, so we have peripheral nerve. So this peripheral nerve will connect to our target organ lah. So here I have muscle. Okay. So for the disease, okay, the disease for today arise from neuromuscular junction. Tiny structure ni between neuron and also the muscle. We have neuromuscular junction. Okay, so disease arise from this area. Ada banyak lah juga sebenarnya, but then in our syllabus I'll be teaching about myasthenia gravis. Bagus kan, satu je you all belajar. And then we have disease arise from the muscle, which can be divided into inherited and also acquired. So inherited kita ada 2, sebenarnya ada banyak, tapi again untuk your level you just have to know these 2, and for acquired these 3 in general. For acquired just in general lah. For inherited this one you must know lah. Okay, these 2. Okay, so dah ada gambaran apa yang kita nak belajar semua, the overview. Okay, now we start with disorder of neuromuscular junction. Okay, so the neuromuscular junction is a specialized interface between synaptic nerve ending daripada neuron ni and muscle fiber. So kita ada muscle fiber kecil-kecil tu kan. And then here we have the neuron and also the muscle. Okay, yang ni ialah the cleft or the neuromuscular junction kat sini. Okay, so here is the presynaptic membrane, here is the postsynaptic membrane. Okay, so the nerve impulses depolarize the presynaptic membrane here and stimulating calcium influx. Oh my god. Stimulating calcium influx and the release of acetylcholine. So acetylcholine will be released into the synaptic cleft kat tengah-tengah ni. And then what happen after that, acetylcholine diffuses across the synaptic cleft and then dia bind kepada receptor on the postsynaptic membrane, leading to depolarization of the myofiber and then contract lah muscle. Okay, so this one you learn already in details from physiology kan, under physiology. So what is myasthenia gravis? Myasthenia gravis is an autoimmune disease. It is caused by autoantibodies, and the target is the neuromuscular junction, and patient will present with a fluctuating muscle weakness. Okay, for etiology, antibody lah, autoantibody. Auto means kita sendiri generate. Okay, so autoantibodies block the function of the postsynaptic acetylcholine receptor. So dalam MCQ selalu dia akan tanya, dia akan trick you all lah. Kadang-kadang dia akan tulis presynaptic. So nak tahu you all tahu ke tak. So dia postsynaptic, maksudnya dia dekat muscle tu. Okay, so this is the nerve, this is the postsynaptic membrane. So nampak tak yang YY ni semua? So the YY ni lah antibody tu. So antibody ni compete with the acetylcholine. Acetylcholine sepatutnya duduk dekat reseptor ni, tapi sebab antibody dah duduk kat sini, dia tak boleh pergi kepada reseptor. Okay, when the acetylcholine cannot attach to its receptor, what happen to the receptor? Receptor akan degraded. Sebab dia tak ada kerja nak buat kan, tak ada, no duty. So dia akan degraded. Lepas tu, after sometimes, this postsynaptic membrane will be depleted of receptor. So tadi kan kita belajar bila ada repolarization from the neuromuscular junction, from the pulse, and then the muscle will contract kan. So now because of this inhibition, muscle activation is inhibited. So tak bolehlah contract. Alright, so 30% of patient, particularly young patient, okay, have thymic hyperplasia. And 10% of patients have thymoma. Okay, and this thymic lesion may perturb tolerance to self-antigen. Okay, dia akan thymus kan produce kita punya lymphocyte kan. But then when a child grown up, dia punya thymus akan regress. But then in this patient, the thymus persistent, okay, in the body. So dia akan hasilkan autoantibody. And but not all patients with myasthenia gravis ada thymic abnormalities. So some cases, especially in older patient or those patient yang not associated with anti-acetylcholine receptor autoantibodies. So patient yang bila kita check tak ada anti-acetylcholine receptor autoantibodies ni, dia tak ada thymic abnormality. Okay, so what kind of antibody yang dia ada? So there are two other common in myasthenia gravis, two other pathogenic antibodies. One is muscle specific kinase and the other one is low density lipoprotein receptor related protein. Satu nafas je. Okay, this one you good to know, but tak payahlah memorize sampai pecah-pecah neuron. Okay, so I just hope that you know about this anti-acetylcholine receptor autoantibodies. Ni pun I dah happy dah kalau you all tahu. Okay. Right, the pathogenesis. Pathogenesis important. So after the body produce antibody, again anti-acetylcholine receptor antibodies. Di short form dia lah. Ni acetylcholine, ni receptor. Okay, tapi dalam exam please letak nama penuh. Okay, this antibody, what it will do, it will block the receptor. Okay, just like what I've mentioned earlier, and what happened after that, degradation of the receptor occur. And not only that, at the postsynaptic membrane, dekat membrane, there is this antibody also will induce damage by complement fixation. So dua benda lah. Okay, the net result is receptor depleted and postsynaptic membrane morphology is altered. Okay, and these two will cause no contraction of muscle. Therefore, the muscle will be weak and patient will have muscle weakness. Okay. Alright, in patient with myasthenia gravis, the symptom usually almost always begin with ocular muscle weakness. Ocular is the eye scan. Okay, and then some of the patient also may have oral muscle weakness. So yang pink ni nampak tak? So this up to 95% will of patient will have this type of muscle weakness. Okay, and 60% will have proximal muscle weakness. So proximal muscle maksudnya yang dekat dengan torso kita kan. So dekat shoulder and also dekat thigh. Alright. So the degree of muscle weakness varies greatly among individual. Okay, ada orang yang teruk sangat, ada orang yang very mild. And the onset of the disorder usually sudden. The patient will in early stage dia akan rasa okay in the morning, so dia pergi kerja, okay, pergi kerja in the morning, okay je rasa, but then petang-petang dia dah start rasa tired, fatigue, okay, and then ada diplopia and also speech slur. And selain daripada weakness of the eye muscle, patient also will complain of facial paralysis, change in voice, drooping position of the head, difficulty in talking, difficulty to climb stairs and lift object, difficulty to chew and swallow, and last but not least, breathing difficulty. When the doctor check the patient, bila you all the doctor, you all check patient, patient will present with diplopia, okay, diplopia and also ptosis due to involvement of the extraocular muscle. So here, patient ada apa ni? Diplopia ke ptosis macam ni? Ptosis, okay. Ptosis. So diplopia is double vision. That one you have to check the patient. And the patient will complain dia nampak dua objek yang overlap with each other. Alright, so facial weakness, patient will have will not able to hold the mouth closed. So macam mana rupa dia nanti kejap lagi kita tengok. And then the severity of the weakness often fluctuate dramatically, sometimes over a period of only a few minutes. Okay, and then repetitive use of muscles make the weakness more severe. So this is diagnostically useful. So ingat myasthenia gravis ni makin guna muscle tu makin dia weak. Okay. Alright, so clinical manifestation. So clinical manifestation, kita buat physical examination to the patient lah. So yang the two most common physical examination, one is neurasthenia fatigue and recovery test. Another one is eye spec application test. Okay, this one ingat, this one ialah bedside or physical examination, bukan investigation. Kalau keluar exam, tolong jangan jawab eye spec application. I gigit tangan you all. Okay, this one is not investigation, this one examination, because many times when I ask student what is investigation, you bagi I examination. Examination, you examine patient. Investigation, you do laboratory investigation, you do imaging. That is investigation. Okay. So when you ask the patient, okay, ni tengok dia dah get ready ni patient ni. At 0 second, you ask patient, okay, ma'am, please look at this reading material and try read it out loud for me. So patient tu pun baca lah. Clinical manifestation, dia tengok the reading material that you are holding, or you nak letak atas meja pun boleh. And then after 30 second dia dah start jadi macam ni, mata dia dah start drooping kan. And then at 30 second or 40 second dia dah start jadi macam ni. Do not get angry to the patient. This is not because patient mengantuk, okay? This is because of myasthenia gravis. Okay, and patient kan you ask the patient to read as well, right? So by time you will see there is positive hanging jaw sign where the patient unable to hold the mouth closed. So mula-mula dia bolehlah senyum sambil baca kan, and then after that tak boleh dah, mula mulut dia dah start jatuh. Okay, the drooping of the labial fold. And then that is one examination, and then we have another one which is ISPEC test. So this ISPEC test, in this patient dia ada unilateral left-sided ptosis. So this patient dia ada bilateral, this one unilateral. So as I said earlier, the clinical manifestation or the symptom patient might manifest varies. Okay, ada orang bilateral, ada orang unilateral. So in this patient, ISPEC application over the left eye for 2 minutes help to improve the ptosis by more than 2 mm. Tadi mata dia macam ni gini kan. So after application of the ISPEC, the ptosis get better, but then just for 7 minutes je mata dia boleh buka macam tu, and then dia turun balik. Okay, so the what is the significance of this ISPEC test? It was said that it because of the inhibition of the enzyme in the neuromuscular junction. Okay, you don't have to know details about this. You just have to know the findings. Okay, because in exam we will ask like, okay, what happened to this patient? What do you call this? You jangan tulis kat situ sleepy eyes. So memang kalau you tulis sleepy eyes memang tak akan dapat markah, and then I cari you all based on your metric number and then this one the hanging jaw sign positive. Alright, okay, next one. Okay, the investigation. Okay, this is the investigation to confirm the diagnosis. Okay, investigation to confirm the diagnosis, kita akan buat antibody test. Okay, antibody test to look for anti-acetylcholine receptor antibodies. You jawab macam ni pun I dah happy dah. Okay, full mark. Alright. So the complications usually myasthenia gravis, patient with myasthenia gravis dia ada good prognosis. Okay, patient usually will recover well, but then in some of the patient they might develop complications. So complication that the patient might get myasthenic crisis. Okay, this is a complication of myasthenia gravis characterized by worsening of muscle weakness resulting in respiratory failure. Okay, so patient might need ventilation. Itu yang bahaya dia. Okay, so why? What happened? Because the respiratory muscle get too weak to move enough air in and out of the lung. Dia nak inspire, nak exhale, nak inhale tak boleh. Because when we inhale and exhale, we use our muscle kan, the abdominal muscle as well, and also the diaphragm, right? And other than that, the complication is the long-term use of immunomodulating therapy. Okay, so dia ada banyak drugs, and one of the drugs to modulate the immune system, usually the doctor will use steroid. Okay, the use of steroid, as usual, you know, right? The side effect of steroid banyak. Okay, some I put up here: osteoporosis, cataract, hyperglycemia, weight gain, hypertension, okay, opportunistic infection, and GI symptom like or GI disorder like gastritis or peptic ulcer disease. Alright, so banyaklah complication dia, okay. Okay, now we've come to the second part, the disorder of skeletal muscle. So myasthenia gravis tadi, gitulah you all perlu tahu. Apa yang I mention, itulah yang keluar exam, itulah yang akan ditanya. Because dalam Robin, coek dia kan, dia punya information, tiket je. So the one that I've presented here is the one that you will be asked. Okay, in exam lah. Alright, now disorder of skeletal muscle. Okay, as I've mentioned earlier, we have inherited and also acquired disorder of skeletal muscle. Inherited, we have dystrophinopathies. Inherited sebenarnya banyak. Okay, kalau you all baca kan macam banyaklah, dia ada congenital. Kalau inherited ni maksudnya something that involve your gene kan. So bila something involve your gene, it can banyak gene dalam our body can leads to disorder of skeletal muscle. So adalah yang susah-susah nak sebut pun ada, dan ada yang congenital. Okay, dystrophinopathies is not congenital. Okay, what does congenital means? What does congenital means? Semua pengsan. Tak tahu, nak jawab.
Ada tu.
Apa dia?
Inherited. Dia
Inherited. Oh,
Inherited from genital.
inherited is congenital. Is that what you mean? Is that what you mean? Inherited equals to congenital.
nah.
Okay. Okay, inherited, congenital betul. So, macam some of the congenital disease may be an inherited. Okay, some, bukan semua. So kita ada, for example, congenital syphilis. Congenital syphilis bukannya inherited, betul tak? So apa maksud congenital actually?
Segi dapat daripada lahir.
Yes, very good. Okay, so congenital maksudnya daripada lahir. Okay, so congenital tak bermaksud inherited, sebab congenital syphilis bukan inherit. Okay, dia transmitted because of infection. Okay, this congenital maksud dia the manifestation, the symptom, the sign you can see masa dia lahir lagi. Okay, that is congenital. But for inherited disease, ada congenital and bukan congenital, non-congenital. So maksudnya ada yang you nampak daripada lahir, ada yang you nampak sebelum lepas dia dah besar lah. Okay, so these two is not congenital. Okay, these two is not congenital. So you will not see masa lahir tu you terus tahu, oh patient ni ada Duchenne, oh patient ni ada Becker. No, tak boleh. Sebab the manifestation is later in life. Okay, bila nanti kita go to the next slide. And then for inflammatory myopathies, this is a collection, or this tree is a complex diseases with variable phenotypes. So kalau you just have to know in general. Okay. Okay. So inherited diseases of skeletal muscle, dua je you all tahu. So dia ada banyak lah dalam buku ni. Nak sebut pun kadang-kadang tak berjaya. Ini dua je tolong sebut betul-betul, Duchenne and Becker. Duchenne and Becker. Okay. So these two quite common compared to other inherited diseases of skeletal muscle. Alright, as an overview again. So dystrophinopathies nampak tak plural ni, plural. So maksudnya dua-dua lah. I'm referring to dua-dua, Duchenne and also Becker. So these two are X-linked recessive diseases. Okay, X-linked recessive diseases. So X-linked recessive diseases selalunya affect boy ke girl?
Boy.
Boy.
Okay. Okay, usually it will affect boy. What happened to girl? Girl selalunya jadi apa?
Carrier.
Yes, carrier. Very good. Okay. So usually girl ataupun female is the carrier, boy usually affected. Alright. So antara Duchenne dengan Becker, Duchenne more common and Duchenne more severe. Okay, more common, more severe. And then the etiology ni kalau keluar exam janganlah panggil doktor tanya what is etiology. Etiology ni cause. Okay, so the etiology is dystrophin gene mutation. Okay, what is dystrophin gene? Okay, now we go to next slide. Okay, before that, okay, this is what I asked you earlier. So X-linked recessive inheritance, as in patient with Duchenne or Becker. So patient usually will get from the carrier mother or affected father. Okay, so one gene is enough to cause the disease. So kalau mother is a carrier, the son will have like 50% chance to get the disease. Okay, another 50% maybe normal, another 50% might be affected. Okay, the daughter will be also 50% unaffected, normal, and another 50% will be carrier. Whereas if the father is affected, the daughter will be carrier because it is X-linked kan. So X tu wajib lah pergi ke anak perempuan dia. Kalau tak macam mana nak jadi anak perempuan kan. So anak dia akan jadi carrier. And because the father give Y only to their son, so none of the son will be affected. Alright, dystrophin. What is dystrophin? Okay, dystrophin ni depends lah gene ke protein. Kalau gene, okay, now we talk about gene. So gene dia duduk sini, ni X chromosome. So this is P arm, this is Q arm. P is the petite, short arm. P petite maksudnya short arm, Q is long arm. After PQ lah kan, A, B, C, D, E. Baca A, B, C, D sampai PQ. So PQ. So P is short. So it located at the XP21. In genetic, we don't say XP21. Nanti bunyi macam tak belajar genetik kan. So XP21. Okay, that's how you say it or pronounce it. XP21 kat sini. And this is the largest gene in our body. Therefore, it vulnerable for sporadic mutation. So sebab dia lagi besar, lagi terdedah kepada bahaya kan. Kita banyak-banyak chance untuk get mutation. So most common mutation are deletion and point mutation. And this gene encoded for dystrophin protein. So daripada gene, our body will produce protein, which is dystrophin protein. So this dystrophin protein are found in skeletal, ada kat skeletal muscle, ada kat cardiac muscle as well, ada dekat brain as well, and also peripheral nerve. Okay, and this dystrophin protein, it is a part of dystrophin glycoprotein complex. Apa pula DGC ni kan? What is DGC? Dystrophin glycoprotein complex. Alright, next slide. Dystrophin glycoprotein complex. Okay. This complex, as you can see here, it is a large multi-protein complex, consists of dystrophin, nampak tak dystrophin ni, and then other protein as well lah. Nak sebut pun tak reti, tapi kita try sebut dystroglycan, sarcoglycan, syntrophin, and also dystrobevin. Syntrophin here, dystrobevin here, okay. So ni dalam cell, so in the cytoplasm, this is outside of the cell. So the function of this DGC is to link the cytoskeleton actin, which is in the cell, to the extracellular matrix. Okay, so dystrophin provide mechanical stability to the myofiber and its membrane during muscle contraction. So it is important for muscle contraction, this DGC. And DGC also involved in signaling pathways, interact with one enzyme, which is nitric oxide synthase, to generate nitric oxide. So this nitric oxide is very important for the muscle, for the skeletal muscle, to take the glucose during muscle contraction. The pathogenesis of dystrophinopathies. Okay, when mutation occur in the dystrophin gene, the X chromosome, what happened after that? It will produce mutated dystrophin. So this mutated dystrophin will form the complex, the DGC, okay, the dystrophin glycoprotein complex. So when it form the complex, because of the defect in dystrophin, it won't be able to perform its complete function, okay, its complete role. So what happened after that? It cannot protect the membrane. There will be transient membrane tear. So this transient membrane tear will lead to constant influx of calcium into the cell, into the skeletal muscle cell, and this will activate the proteases. And on the other hand, there is also signaling disruption. Okay, so tak bolehlah produce nitric oxide. Therefore, these two will lead to myofiber damage and also necrosis. So myofiber will try to dia nak buat balik baru, tapi jadi lagi ongoing myofiber damage and necrosis. They cannot regenerate. Okay, if it's able to repair itself, it only will be able to repair or replace muscle tissue with fibrosis and also fat. Okay, and then because of this will lead to also formation of fat cell in the skeletal muscle, which is known as pseudohypertrophy. As you can see here, ni patient ni dia bukannya pergi gym tau. So this is because of the enlargement of the muscle. Nampak besar tapi very weak. Kenapa? Because it's not consist of all skeletal muscle. It consists of fat as well. Right? Okay, the clinical features. Okay, usually patient Duchenne and patient with Becker normal at birth, lahir normal, and very early motor milestone are met. So the child will be able to prone to supine, lepas tu dia boleh melangkah. But then bila dia nak start berjalan, selalunya delay. So walking is often the fear of marks are and inability to keep up with peers. So and the weakness begin in the pelvic girdle muscle and will extend to the shoulder girdle. So here, as you can see in this patient, the child arise from prone position. Ni prone position macam mana dia nak bangun bila dia baring macam ni kan. So this child need to use his both hand to get up, and how he get up, this is what we call as Gower's maneuver. He need to use this kind of maneuver. Kita kalau nak bangun melompat terus pun boleh macam ni kan. But then this patient cannot because of the weakness of the muscle. Okay, so in this movement, the most important thing you need strong gluteal muscle, which is here, and also strong spinal muscle kat belakang, right? So when the patient able to stand up, you can see the patient stand in lordotic posture. Macam ni, dia macam lordotic kan, kalau kita straight lah, tak adalah straight sangat, but then this is lordosis, nampak tak dia punya lumbar, lordotic posture. Okay. Right. And then, so how to differentiate with BMD? Okay, to differentiate with BMD, before that, okay, in DMD, Duchenne, the age of onset usually around 2 to 5 years old. It will be a bit delayed in BMD at age of 8 to 10. Patient will be able to ambulate, dia boleh gerak sendiri until age of 11 lah, alright, in DMD. And then after that, the child will confine to wheelchair by the age of 12. Okay, and then contracture occur early. And patient with DMD, then as I told you earlier kan, the dystrophin bukan not only in the muscle, also in the brain as well kan. So it will also affect the brain. Therefore, it will the child might have learning difficulties and also cognitive difficulties. So their intelligence might be subnormal, okay, kurang daripada normal. And then other than that, tapi compared to BMD, BMD child, the IQ is at normal level, right? And then other than that, dystrophin also can be found in heart as well, right? So because of the mutation of the dystrophin, defect of the DGC, the heart function will be decreased, and patient also might have cardiomyopathy, and this will lead to heart failure. And not only heart, other site that will be affected is the diaphragm. Okay, sama macam sonography tadi. So weaken the diaphragm, and the patient might require ventilator. Okay, sebab bila diaphragm tak kuat, you nak cough pun tak boleh, and then the patient might get pneumonia easily. So most patients don't survive their mid-20s. Okay, so the lifespan of patient with DMD shorter. Okay. Compared to BMD, the lifespan of a patient with BMD usually almost normal. Right, the investigation. So someone is talking?
Okay.
Can you hear me?
Yeah.
Yes.
Okay,
Yeah.
can I ask?
Yeah.
So based on the when we compare between BMD and DMD, so could we say that actually DMD is more severe because they are caused?
DMD, you mean Duchenne?
Yes.
Yeah.
So they are actually the same thing, but DMD is more severe.
Why? Do you know why?
No, I don't really know about it.
Okay, it's okay. I will teach you. This is the time that I will tell you later. Okay. Okay. Mesti you all terfikir. Dua-dua sebab dystrophin gene. Tapi kenapa yang tu okay, yang tu boleh lah. And this one is very severe sampai at the age of 20. You all dah 20 something kan? Patient with Duchenne unable to reach their 20s. Okay. So why? Ada jawapan dia. Sekejap lagi laju sikit. Okay. So the investigation. Okay, we go to investigation first. Before I feed your curiosity, so we learn about investigation first. So serum creatine kinase. Okay, so creatine kinase. Creatine kinase bila you check your cell, creatine kinase ada dalam sel. Okay, so this creatine kinase because of the lack of dystrophin to keep the muscle from the when our muscle contract, this will injure the muscle, the cell, the muscle cell. Okay, so because of lack of dystrophin, what happen is the membrane will be tear. Okay, the tearing of the membrane will make the CK will leads to leak of the CK from the cell into the serum, into our serum. Into our blood. So when we check the blood, CK very very high. Okay, when we check the blood of patient with dystrophinopathies, dia punya CK level very high. And then other than that, we can check the muscle. Buat muscle biopsy, take the muscle, look under microscope, and then for what? Because we want to see the morphology of the muscle, and then you will see there is fibrosis, there is presence of adipocyte. Okay, adipocyte in the muscle. And also you can do special staining to see the dystrophin in the muscle. Other than that, we have electromyography. So this electromyography will show that weakness is caused by destruction of the muscle tissue rather than damage by nerve. Okay, and the last one, we should send patient blood for genetic testing. Okay, because we want to look for type of mutation or is there any mutation in the dystrophin gene. Okay, why we need to look for genetic testing? Okay, so just now your friend was asking why DMD is. It seems like DMD is more severe compared to BMD, but the cause is the same because of the mutation in dystrophin, kan? So why DMD is more severe compared to BMD? Because different type of mutation. Okay, dalam badan in one or in certain disease, mutation ada macam-macam. Okay, I'm sure you all already learn there are many type of mutation. So mutation in Duchenne dystrophy will result in severe absence of dystrophin because the gene will not produce dystrophin protein, whereas in Becker the type of mutation will produce shorter dystrophin gene or truncated. Okay, dia pendek dan function dia tak fully function. In dystrophin tak ada langsung. So maybe there is less than 5% dystrophin dihasil bila kita check ada less than 5% of dystrophin in the muscle. Okay, maybe produce oleh ada place kita tak tahu because dystrophin protein produce oleh mainly by dystrophin gene. Tapi maybe other gene can produce juga, which leads to less than 5% of dystrophin. Okay, so the answer is because of different type of mutation. Okay, this mutation will lead to absence of dystrophin protein. Mutation in Becker will lead to shorter or truncated dystrophin protein. That is the answer. Okay. And this has been proved from the muscle biopsy, macam mana kita tahu benda ni, because muscle biopsy specimen from patient with DMD will show absent bila dia buat staining. Staining that kind of staining is to know the presence of dystrophin. Patient with DMD Duchenne, dia punya staining memang tak ada. Okay, tak ada staining. Okay, Whereas patient with BMD ada, but then very faint ataupun less compared to the control normal people. Okay, thus the severity of disease correlates with the degree of dystrophin deficiency. So kalau keluar exam, which is I don't think so lah, I will ask you this kind of question. It's just that you have to know why BMD less severe, because BMD the mutation produce truncated dystrophin. Duchenne the mutation will lead to very severe absence of dystrophin, different type of mutation. If I tell you about the mutation, it will take another 1 hour of lecture. Okay. All right, the complication. Okay, so the complication of dystrophinopathies, especially in DMD, the complication is more significant. You can see more complication in patient with Duchenne, because here as example contracture. Okay, so contracture, a patient will have contracture, and this contracture usually this contracture is due to several factors, okay, including loss of full joint range of motion, so data, and then immobility. Patient will move less, okay, because of the weakness. And then the static positioning, patient akan duduk static je, okay, sebab dia tak boleh move dia punya arm or legs. And also muscle imbalance around the joint at the back. Okay, at the back, at the arm, at the legs. So this will lead to contracture. Okay, and another one is scoliosis. Okay, patient scoliosis, patient with DMD prone to get scoliosis because the poor mobility and the increasing muscle weakness. Okay, this will change the spine position. And another one is respiratory insufficiency or respiratory failure, pneumonia, and cardiac decompensation. And patient with BMD, usually the complication is cardiac failure. Okay. All right. Now we've come to the acquired diseases of skeletal muscle. Okay. Yang tadi important part, the myasthenia gravis and also the dystrophinopathies, yang tu yang important you all have to know. Okay, the what do you call that, the HPE, you don't have to worry. Memang dalam buku Robin ada cerita pasal HPE of Duchenne kan, but then you don't have to worry. Duchenne and Becker ada special staining pun dalam tu, you all boleh tengok, but then it won't be asked in exam lah. Alright, you just have to know the one that I'm teaching you, the etiology, the pathogenesis, the clinical manifestation. Right, that is the most important one. Okay, for acquired diseases of skeletal muscle, okay, we have these 3: polymyositis. Okay, polymyositis, poly maksudnya banyak, myo maksudnya muscle, okay, and tis belakang ni maksud dia inflammation. Whereas dermatomyositis, dermato maksudnya skin, alright, myo muscle, belakang ni inflammation, tis ni inflammation lah, alright. And then the last one is inclusion body myositis. Okay, so polymyositis also an autoimmune disorder. Okay, dia sama macam myasthenia gravis, autoimmune. So maksudnya ada related to generation of antibody. Alright, so the pathogenesis of polymyositis is associated with increased expression of MHC class 1 molecule on myofiber and predominantly endomysial inflammatory infiltrate containing CD8 cytotoxic T cell. Okay, this cytotoxic T cell will cause the damage of the myofiber. Alright, so when you check the patient punya HPE, you will see there is endomysial inflammatory infiltrate and also myofiber necrosis here. Okay, don't worry about this thing. Okay, I won't. This is just for you to know. Okay, and the clinical manifestation. Okay, patient because this is related to muscle, and So patient will complain of weakness, affect many different muscle in the body, especially at the shoulder, hip, thigh muscle, semualah banyak tempat. So patient akan complain ada foot drop. Patient will have morning stiffness, and then neck muscle weakness, fever pun boleh ada juga, and then joint pain, weight loss. Okay, very unspecific symptom. But then there is no skin rash. Okay, sebab nama dia polymyositis kan, weakness of the muscle dia, not related to skin at all. Okay. Compared to dermatomyositis. Okay, this dermatomyositis, as its name implies, dermato maksudnya kulit lah, dermato kan. And then this is also autoimmune basis. Okay, it's due to type 1 interferon induced gene product which is strongly upregulated in affected muscle. Okay, some patient may have autoantibodies, okay, that related to this. This actually not well understood. Okay, if you know that dermatomyositis because of these specific antibodies, and will leads to the manifestation of the skin and also the weakness, itu pun dah cukup bagus lah. Okay, so the clinical manifestation apart from the skin rash, it will affect the joint, the esophagus, the lung, and less commonly the heart. Okay, yang tadi weakness of the muscle, more common here, the yang dalaman as well as the joint, right? And this is how it looks like under microscope. Dermatomyositis often show prominent perivascular and paraseptal atrophy. So you nampak the size of the muscle ni tak sama dengan yang dia dekat tepi-tepi septal ni ada atrophy. And then just for you to know. Okay. So inclusion body myositis. Okay, so this inclusion body myositis is quite rare lah. Right? The etiology is because of the degenerative process with secondary inflammatory changes, unclear cause. Okay, kalau unclear cause tu maksudnya dia pun tak pastilah. Okay, yang dia tahu, yang apa yang so far the thing that we know, it is because of the degenerative process which usually in older people. So usually dalam around 60 years of age. So the pathogenesis, the aggregates of the same protein that accumulate in the brains of patients with neurodegenerative diseases, the tau protein, amyloid derived from beta amyloid precursor protein, and TD43, okay, leading some to speculate that this is a degenerative disorder of the aging. Okay, you just have to know it is because of the protein that accumulate in the muscle. Okay, yang dekat patient with Alzheimer kan, dia ada tau protein. Patient with Alzheimer akan ada this kind of protein as well dekat brain dia. Tapi in this inclusion body myositis, dia ada dekat dia punya muscle cell. Okay, so the clinical manifestation, patient will have progressive muscle weakness. So usually it will affect the quadriceps, the distal upper extremities muscle, and patient also will have dysphagia, okay, difficulty to or pain. Yes, you want to ask question? Yeah, okay. Pain during swallowing. So here you can see the inclusion body myositis showing myofiber containing rim vacuoles, inclusion with reddish granular rimming. Okay, the complication of inflammatory myositis because of what patient have. This patient, these three type of patient of polymyositis, dermatomyositis, and also inclusion body myositis. This inflammatory myositis patient will have a complication of aspiration pneumonia, okay, and also hypoventilation because of the weakness of the muscle. especially the breathing muscle, okay, the muscle that involved in breathing. And also a patient might have at the same time interstitial lung disease. Okay, the association of interstitial lung disease with inflammatory myositis is because of the autoantibodies. Okay, it will affect the lung as well, and dysphagia. All right, that's all for today. This is my reference. You can refer back if you don't understand. And if you have any question, just mana buat. Salah. Okay. Awak nampak? Mana? Oh. Awak tak boleh. Okay. Okay. Do you have any question? If you belum dapat idea, belum dapat ilham lagi nak tanya apa, you can just message WhatsApp me. If you don't have my WhatsApp, you can email me. Okay, I will entertain your question. Other than that, please memorize, please understand all my slides because this is the concise one. Okay, very concise for you to understand. Okay. Any question?
No, Doctor.
Okay. Yes? Tak ada Okay. All right. Thank you everyone. Thank you. Thank you for your attention and I'll see you next time. Okay, bye.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Bye, Doctor.
Doctor.
Thank you.